So Dr. Ramamurthy is going to talk about management of deficient capsules. Thank you.
Good morning, and thank you, Dr. Maipal, for having me in this wonderful course. The topic I'm going to be covering is management of the deficient capsule. I think the immediate goals when you have this complication is to extract all of the nucleus, remove the cortex and epinucleus, reducing the amount of drop lens matter to the extent possible, do an adequate anterior vitrectomy, preserve residual capsular support as much as possible, and just in case you feel you can get away with it, in the first step itself, implant an IOL. So I'll be just showing a series of videos just to emphasize these points. This was a fairly straightforward case, I thought, where you can see a reasonably hard nucleus, but otherwise good sized rexes, then conventional phaco chopping being done with my normal settings. All the videos are running at 2x speed, so don't bother if it's a little jumpy. I thought everything was under control, but then towards the end of the nucleus fragmentation, what I noticed was there was a, while I was doing the irrigation aspiration, I had created a small rent over there. It's a well circumscribed rent over here, and before I'm removing the irrigation cannula, I'm injecting a dispersive viscoelastic so as to tamponade the anterior vitreous space. That is the area of the rent, and basically there is adequate capsular support peripheral to the area of the rent. So what I'm doing in this case, the patient was to receive a single piece multifocal implant, and that's exactly the lens that goes in, because it's also a toric multifocal, and because I'm confident of the fact that there is some rexis support available. I have not done any anterior vitrectomy in this case because the anterior vitreous space is tamponaded, and though the orientation of the haptics has to be around the area of the rent because there's a capsular support available, as you can see with the digital overlay that will come on towards the end, I'm able to exactly position the lens in the direction where it's meant to be. Obviously, a good idea to always check with Ramstone estate to make sure that there is no vitreous in the anterior chamber. You can see a good rexis overlap, a lens in the bag, a single piece multifocal toric lens with a reasonably large capsular rent. Of course, this is occurred towards the end of the surgery when I was just doing irrigation aspiration. It was a well-confined rent. Obviously, whenever you have to do an anterior vitrectomy, we're all aware of the IA cut and the cut IA mode, and these are the parameters that I use. Now it's a slightly older photograph. Now the maximum cut rate that's available in my machine is 5,000, and that's what I use. Gentle parameters, IOP of 30, which is what I use in almost in all steps of my cases, vacuum and aspiration being also under control. The most important aspect is you use the cut IA mode, that is you cut the vitreous first and then aspirate, and not the IA cut mode. Just in case you want to switch between the two, all you have to do is from the cut IA, you go into the irrigation aspiration mode, and then the vitrectomy cutter just starts working like a normal irrigation aspiration cannula. Whenever you have to cut the vitreous, you go on to the cut IA mode using gentle parameters like this. And this is the initial chopping itself I'm doing, and as you can see over here, there's a fairly large rent that's developing over there. Immediate step is there's quite a bit of nucleus left over. Dispersive viscoelastic is what goes in, but because that gets retained, and that tamponades the anterior vitreous space quite adequately. I'm gently shifting out over all the nucleus matter in the anterior chamber, using fairly gentle parameters, just the right amount of energy. I'm going ahead and removing the nucleus matter, repeatedly tamponading the area of the PC rent, and then subsequently my Sinski hook also acts as a to hold back the nucleus in the anterior chamber. Obviously, the patient is going to undergo a good vitreoretinal examination in the immediate postoperative period to make sure there's no lens matter in the AC. But as of now, all the nucleus seems to have been removed, and the rest of the irrigation cannula is also, irrigation aspiration is also completed. Make sure using the Vexel sponge, in case there's no distortion of the rexis margin or the pupillary margin, that itself tells me that there's no vitreous in the AC. Because initially the patient was to receive a single piece lens. Now I have shifted over three piece lens I enlarge the rexus, enlarge the incision, and then subsequently I'm placing a 3-piece lens and creating an optic capture. This is one of the best lenses, the best ways of dealing with whenever you have a adequate PC rent. And I have cases which I have followed up for 20, 25 years after a PC rent with a good 3-piece lens placed with the optic capture with excellent visual outcome which the patient maintains. And another situation, there's a fairly hard cataract. Again, everything seemed to be under control. I'm staining the capsule and going ahead with the surgery. Once the first heminucleus is removed, I find that there is a significant rent that's developing. Here again is a situation where the anterior vitreous face is not disturbed. So what I'm doing now is the first heminucleus is out, but I am going ahead with the second heminucleus. I realize that there is tilting into the vitreous face. So what I'm doing is to bring in the nucleus fragment into the anterior chamber, then introducing viscoelastic and introducing a 3-piece lens in the sulcus. Basically, the lens itself acts as a tamponade. It partitions the vitreous cavity from the anterior chamber so that the propensity for the lens matter to sink into the anterior chamber is significantly diminished. Even in case you are using a single-piece lens, you can place it in the sulcus or in the bag and then subsequently position the lens after the nucleus fragment is removed. Once the lens is there, I am more confident there is less chances of the lens material to slip into the vitreous cavity. And now the irrigation aspiration, that's a vitrectomy which is being done behind the lens. I'm going behind the lens and doing adequate amount of vitrectomy. Always use diluted triamcinolone acetate to ensure that there is no vitreous trans in the anterior chamber. And again, I always do this test where a regular pupil and a regular rexus tells me there is no vitreous in the anterior chamber. Obviously a difficult issue, but then you have dealt it with the best possible manner. This is just to show you to look at the simple cues that might tell you there could be a vitreous disturbance. Again, everything seemed to be under control and this surgery was proceeding quite smoothly. But as I evacuated the vitreous, the lens quite completely, you can see this simple distortion over here, which is pointed out by the arrow over there. That without any chafing of the iris, this kind of a distortion itself tells me there's something wrong. I'm injecting viscoelastic. I think I can implant a lens in the back, but then I realize there's vitreous in the AC. I just go ahead because the PC is intact. I think it's a capsular dialysis that has occurred. So implant the lens in place, but you can see there's obviously vitreous in the anterior chamber. And because it's a capsular dialysis that's responsible, I introduce an endocapsular ring. Introducing an endocapsular ring into the capsular bag with a single-piece lens is always a challenge, and there is a tendency for the lens to get displaced. I reposition it and then subsequently do an adequate anterior vitrectomy. Once again, the lifesaver triamcinolone acetate comes in, and then you can see there's a wick of vitreous that's coming at around this 12 o'clock position. That's essentially through a capsular dialysis with the posterior capsule itself being quite intact. Once I'm able to address it quite adequately with the endocapsular support for the capsular bag, I'm having a lens in the bag. In case you have a soft nucleus and which has dropped in, oftentimes it's asked whether you implant a lens if you have a problem like this. As you can see over here, this is a fairly soft nucleus. And in this case, you can go ahead and implant a 3-piece lens and create a good optic capture after doing an adequate anterior vitrectomy. And then subsequently, your vitreoretinal colleague can deal with the lens matter quite adequately. And that's the 3-piece lens that's gone in and the optic capture that has been created. Obviously, you're not going to mess around with the lens material behind, and your colleague is going to deal with it. Just in case you have a hard nucleus fragment, like in this case, which goes in, nowadays with the kind of fragmentome that's available and the kind of technology that's available, our vitreoretinal colleagues are able to deal with these cases quite adequately. But just in case you feel that the patient has to be referred elsewhere and there's going to be a time lag, it might be a good idea not to put the lens in place, because with an intact rexus, there is a small rexus runoff over here, just suture up the incision and then go ahead and refer to the vitreoretinal colleague. I think the most important message is not to chase this. As you can see, this is the final video of mine. This is the kind of treatment that a dropped nucleus requires. So obviously, when you are going to chase it with your vectis or something, they're creating considerable traction on the vitreoretinal, on the pars plana, creating dialysis, etc. And CME is something that's difficult problems to deal with. So when you have, it has gone beyond your limits, better refer it to a VR colleague. Thank you so much for your kind attention.
Thank you very much, Dr. Ramamurthy, for the management of PCRs and deficient. Any comments, any questions before we, yeah, please. Go ahead.
Good morning, sir.
Yeah, we can hear you.
Sir, my question is that how do you explain rent occurring in these cases? You have done everything well. You have removed the lens piece very well.
Please come closer to the mic. No, closer to the mic, just like.
We have done surgery very well. We have take out the lens very well. Then at the time of putting the lens, you find the rent. So how do you explain this rent occurring in this kind of surgery well done?
You mean everything has gone off well while putting the lens, you create a rent?
No, no. You have performed this surgery, you have taken out the lens, and then you find that there is a rent looking at you. So how do you explain rent occurring in these cases?
He's wondering why the rent has occurred.
No, he's one. So basically, you need a good ophthalmologist to check your vision that you missed the rent at that time.
No, I think.
Sometime can there be a capsulocortical adhesion that is taking
but
away
you should be able to visualize. It's just a question that when you have cleared up the entire cortex and the nucleus, that's the time the red glow comes out much better and you're able to visualize it. I don't know if you have to add. You say everything went well according to you, right?
Sir.
Yeah, and then at the end, you visualize the rent.
One video I saw that everything was managed very well. Still there was a rent, and he has to place.
Matlab rent hua kab is your question?
Yeah, how did it happen? Because
no, in the sense that you are quite right. Even in the videos that I showed, there are quite a few times when you feel everything has gone well, and when you are just about to place the lens, you find there is a rent. And like in that one case I showed where there was just a small pupillary peeking, I thought everything was perfect, but then there was a capsular dialysis and vitreous was peeping in. So obviously, any time where there's a imperceptible surge, where maybe your aspiration cannula rubbing on the posterior capsule a little more vigorously than what it should, you can develop a PC red. But the thing is, irrespective of when it has occurred or why it has occurred, you have to deal with it.
no, sir. One problem that I face sometimes, that rent occurred to everyone. Rent occurred to me. I did vitrectomy. I placed the 3-piece. I did the optic capture. And next morning when I do the post-op evaluation, I find the vitreous in the AC. So
See,
how to avoid this situation?
Okay, fine. I think the answer to your question is that once you have put the lens, or maybe there was a smaller rent and the upthrust at that particular time, chamber shallowed and maybe the rent increased, so you are visualizing it better now. It's just a question of visualization. After removing everything and you are visualizing it later, that's about it. I think that's what your question is. So you have to handle it the way it is. Thanks, Ram.
Sir, one question I have.
Yeah.
In the video which you showed the rent occurred before you could complete the phaco. So you put the IOL scaffold and you completed. I got that part. You did the scaffold and did the phaco. But then how do you do the IA, like cortex aspiration, once the IOL is there and a rent is there? Like any tips, like how?
One thing is there, if the vitreous is already in the anterior chamber and it's admixed with the lens material, I don't go for a IOL scaffold. It is when the anterior vitreous face is intact and the lens matter is still there, I go ahead and put, after bringing in the lens, the nucleus fragments are placed into the anterior chamber, I go ahead and place the lens. And after that, after doing the phaco, I go with the vitrectomy, with the aspiration in the anterior chamber, I go with the vitrectomy probe and do an adequate anterior vitrectomy. The same probe itself, as I said, you can switch over to the irrigation aspiration mode and aspirate whatever cortical matter is there.
Okay, with the same probe, with the
Yes.
vitrectomy.
Thank you very much.